You took a printout of that, ma'am.
Sorry?
You're taking a print of that, all these papers. No.
Yeah. I took a printout of what you will want to do. It's easier that way.
Very good. Very good. I just kept a computer parallel to this so that I can see my questions. So I think preparedness is different levels.
Yeah.
We're live and we can start.
Can we start?
Yes, Doctor.
Okay. Good evening, everybody. Warm namaste from all of us. Greetings from Endocrine Society of India. I am Dr. Mohan T. Shenoy. I work as a consultant endocrinologist in Trivandrum, which is based in Kerala. And now today we are gathered here, all three of us, myself, Dr. Vijay Sarathi, Dr. Kirtida Acharya, have gathered from different corners of the world. And we are going to discuss about type 1 diabetes, challenges and opportunities. It is an educational initiative and it is helping the patient for guidance. As we know, type 1 diabetic community is an ever-growing community globally, and there are a lot of miscommunications being circulated in social media, and we are here to dispel all those things. And we are also discussing various case situations which we are encountering in a clinical practice pertaining to type 1 diabetes. So let me have the pleasure of introducing first Dr. Vijay Sarathi. Sir is a professor and HOD at the Vaidehi Institute. It is based in Bangalore, Karnataka. He has been a scholarly doctor and he has been publishing a lot of research in endocrinology. He has got special interest in pediatric endocrinology, having trained from KEM Mumbai, a high volume specialty center in Mumbai. Welcome, sir.
Thank you, Mohan.
Also with us is Professor Dr. Kirtida Acharya. Madam is the national head of the Kenya Diabetes Care Center. She is working at the Kensha Memorial Hospital in Nairobi. Welcome, madam. Hi, ma'am. Okay, so I think we are going to discuss various facets of type 1 diabetes. So I think we will take an opening statement from all of us. Dr. Sarathi, sir, just can you shed a few lines about the etiopathogenesis of type 1 diabetes and how the diabetes in type 1 is different from adulthood?
Right. See, like as probably has also been discussed in the previous sessions, right? Everybody knows now what is type 1 diabetes mellitus, what is type 2 diabetes mellitus. Type 2 diabetes mellitus, it commonly occurs in adults, though recently it is spreading towards the younger age group as well. Whereas still the type 1 diabetes mellitus is more common in children. So if we want to differentiate these two, the type 1 is actually like almost or absolute insulin deficiency, whereas in type 2, there is a relative insulin deficiency, but whatever the insulin is available is not able to properly act because of some resistance for the action of insulin. If you want to look at the cause of type 1 diabetes mellitus, so there are two important things we need to look at here. One, the genetics, one, the trigger. The genetics is actually these are in fact like minor abnormalities in the genes of the individuals with type 1 diabetes mellitus. Just because these abnormalities are present, not everyone will develop a type 1 diabetes mellitus. In fact, these abnormalities may be there in a larger number of the individuals in the population which never manifest with type 1 diabetes mellitus. But those who have these genes and they encounter some trigger from the environment, which could be either in the form of a viral infection or in the form of a foreign body, right? There will be a confusion because there's already some abnormality in the genes. So, and when the particular individual with abnormal genes encounters an environmental trigger, the immune system has to mount an appropriate response only to address that particular trigger or an antigen, okay, which is a foreign body. But what happens because of these genetic abnormality, our immune system is confused. It doesn't mount an immune response not only against these particular triggers, but they also produce an immune response against our own organ. Here in this type 1 diabetes mellitus, that is the beta cells of the pancreas which secrete the insulin. Because of this confusion, the insulin secreting beta cells get destroyed by an immune response, leading to absolute deficiency of the insulin. So in fact, this is the cause of type 1 diabetes mellitus.
That is very clear, sir. I would like to know from Dr. Kirtija Acharya how it is in that part of the region and in Kenya as well as in Africa. I also know that Madam is doing a lot of advocacy work in regarding to type 1 diabetes, type 2 diabetes. I also want to know from her the genetic transmission, how the situation is there in that part. Thank you.
Thank you, Dr. Mon. So in Kenya and in Africa, we do have, in type 1 diabetes, sadly, a lot of children don't even survive up to their 5th birthday or their 10th birthday. First of all, there are issues with diagnosis. So a lot of these kids, they're diagnosed as asthma or abdominal pains, gastroenteritis in the rural areas. So we're trying our best with advocacy and, trying to empower the young mothers and, people out there to recognize the signs and symptoms. But even once the type 1 diabetes has been diagnosed in Africa or in Kenya, we have huge issues, especially with the vulnerable communities, the socially, economically underprivileged communities. Insulin is not free in Kenya. We now have the CDIC program with Novo in our association with Diabetes Kenya, but we don't have enough children who still get free glucometers, free insulin. So in the poorer or the socioeconomically underprivileged communities, even at the government level, we don't have free insulin. So management, we have a lot of, we're still trying with advocacy, we're still trying to get free enough insulin, free insulin and more children in our programs, glucometers. We're trying to get tax, we're trying to advocate with Parliament if we can get VAT and returns and, tax, trying to reduce the tax on importation and reduction on price of strips, but it's still very prohibitive. So as a result of that, when somebody is diagnosed with diabetes, it's very, very demoralizing and defeating when, from in poor household families. And that's why as the chairperson of Diabetes Kenya, we're really still trying to help and support the people, from the underprivileged communities. But in terms of, we do try and get them into programs. We try and make sure that even we get philanthropists and the pharmaceutical companies and whatever we can do to get them, even faith-based organizations, religious communities, to help these children and their families. But despite that, it's not all grim. In the last, I think, 10 years, we have managed to, really empower patients, get less complications, and get more and more children surviving as a continent and in Kenya as well. So that is, the background. And more programs with the World Diabetes Foundation. We've also got more support. We write more proposals. So I think we are much better off than we were, say, 10 years ago with type 1 diabetes and management, prevention of DKAs. And, we've lost a lot of children because of DKA, hypoglycemia, the lack of monitoring, not having the best insulins available, brittle control. When it comes to, so I think that as in a nutshell.
Muted, ma'am. Muted. I think you got muted. Yeah.
I was in an emergency, so I'm using my phone.
Okay,
so it keeps ringing the hospital.
Yeah, I understand.
When it comes to the genetic transmission, we know when Professor Sarathi already explained about the etiopathogenesis, but genetic transmission of type 1 diabetes is quite complex. There are these HLA genes, and we know that there is a genetic transmission in type 1 diabetes. Children who have, they have this something, HLA genes are, chromosomes and genes where it is transmitted. So if somebody has type 1 diabetes in the family, they are more likely to get it, but it's not as common as with type 2 diabetes. There are all these predictions. There are diabetes registries like in Finland and other countries where they're looking. There are these steady registries and DIPP trigger. Even in our own country, we're trying to get a registry. Now with COVID coming in, we are looking more at, what is the connection with, new onset diabetes, even with COVID. So now there's even more interest being generated. But basically with type 1 diabetes per se, if a father has type 1 diabetes, the chances are more of a child having type 1 diabetes more than if a mother has it. I know traditionally women always get blamed if something goes wrong, but with type 1 diabetes, the father passes it in more than the mother, just slightly more. At 7.8% versus say 5.3%. But if both parents have it, the chance is much more. So my advice would be that it's better if two type 1s don't marry. though they tend to marry because they feel that there's a bond or a connection. And then there are many other factors that come into play. Like if we have two monozygotic twins, they share certain factors more than twins that are not identical. So there are many factors that come into play, but of course it's not just genetics. We can't choose our relatives, we can choose our environment, but there are environmental factors that come into play, like breastfeeding, cow's milk, vitamin D, which is known to prevent diabetes. So there's a lot we can do as well to prevent it. So prevention, prediction, that's the whole.
Correct.
Thank you.
That is a good opening line, ma'am. So I think from the first statement, I think we have understood from Dr. Sarathi that the etiopathogenesis of type 1 diabetes is basically autoimmune, and there is also idiopathic variant to this. And from Dr. Kirtida, madam, we have understood the reason why genetic transmission is also one of the things we have to remember. I just want to add that there is also a role for autoimmune progression, and we have also identifying some polyautoimmune conditions like PGA syndromes are also there. So we have also to open our minds, because some conditions like celiac disease, when you have a child with short stature, so many other conditions are also coming into play. So I think hormonal influences, which is why we are all here, hormonal specialists. So hormonal influences on the genetic transmission, these are also important factors. So that concludes the first part of our opening statement. So let us dive into the misconceptions. There is a lot of things which are circulating. The first thing I would like to know from Dr. Sarathi is whether it is a condition which occurs only in childhood, because we have seen that it is a pediatric endocrine section, but sometimes we are also seeing some adults also being diagnosed. Is it a common thing, or is it really confined to childhood only?
It's actually partly true, Mohan, that like majority of the type 1 diabetes actually occurs in children, but it doesn't mean that like adults won't get type 1 diabetes mellitus. In fact, type 1 diabetes can occur at any age in the lifespan. So even a 70-year-old person can also get type 1 diabetes mellitus. But as we enter into the adulthood and as we pass on each decade, definitely the incidence of type 1 diabetes mellitus is lower, right? So, but why it's manifesting very late even in the third decade, fourth decade is there could be two reasons. One, probably though they had the same genes as a child who had type 1 diabetes mellitus, probably the trigger would have come pretty late. So they might not have come to an exposure to any trigger. But there's also something what we call it as like trigger might have occurred in childhood, but the progression of the disease, that's the autoimmune destruction of the type 1, that beta cell destruction might have been very low. So these probably could be the reasons why some adults also get diagnosed with type 1 diabetes mellitus. But to say overall, it's most commonly seen in children, but can also occur in adults.
Okay. Very clear. So thank you, sir. From Dr. Acharya, ma'am, regarding acceptance from the family. So as you know, I think a diagnosis of type 1 diabetes in a young child poses a lot of diagnostic dilemma, but at that time, the society also we have to think around. So the first thing is the family. So I think we had some situations where we had to admit the child for the sake of starting of insulin, because the starting of insulin itself is a challenge. So how is it like in a community perspective as well as in the family perspective? How do you these things from that point?
Thank you, Dr. Mohan. We see a very hybrid sort of kaleidoscope, from different families. I've had such drama when, breaking the news to parents or even extended family members. I've had people weeping, crying. It's like you're actually giving them, news of a death, and you actually, it's very bad for the child. It has very bad psychological effects on the child. And sometimes you have to actually take the parents out of the room, the grandparents, the aunties, the uncles, and tell them, look, it's not the end of life. This is just the beginning of a new lifestyle. And support the poor child. They are the ones you need to focus on, not on yourselves. And sometimes they're very unkind remarks, like if it's a little girl child getting diabetes, an aunt or a grandmother will blurt out who is going to marry her. And this is a 5-year-old child. And how do you come up with a comment like who is going to marry her? Where will we find a husband for her? This child has not even started their puberty, and such questions. So the mother then starts crying. The father looks at the mother and says, it's your fault because your mother has diabetes. They don't even understand the genetic transmission. So it's really, really, all these, I think it's because of what is coming out in the media and, the hype and the community at large. And I think diabetes is type 1 diabetes. First of all, it's the needle and insulin for life. And you know what they've heard in their neighbors and their community. And that's why we as advocates, we are really responsible, and we need to give in, that kindness and that good empathy and that messages that, look, it's just the beginning of a good lifestyle. And then the food thing comes in, because as Indians, we have this food, our life revolves around food. So then what will my child eat? No mithai, Diwali, what will we do? Weddings, what will we do? So, there's so much anxiety. There's so much, they feel the life has ended now. I actually had a father weeping uncontrollably last weekend in my clinic that my life is over, my life is over. And I was saying, look, it's your daughter, we need to focus. And I had to admit her because of diabetic ketoacidosis. But really, we need to really, it's like you have two patients, you don't know who to look at. Emotionally sort out the parents, or, sort out the child who's in decay and you want to admit. And so many times we need a multidisciplined, team approach. You need the counselor, you need the yourself as a doctor trying to sort out the emergency. So the acceptance within the family can be very mixed. And sometimes you have very switched on parents who take it in their stride and they're ready to learn and they're ready to take it. But many times there's denial, there's actually grief. I've seen grief. And sometimes I've had parents who give me a blank check and say, take it, write whatever amount you want, but cure my child. And when that sort of attitude doesn't help, you can't buy a cure. So, I've had all sorts of mixed reactions from different parents. Some are devastated, some are, ready to take it in their stride. So that's why it's not a one man or one woman show. And it's a journey. This is not like malaria or TB where you write, a course of medication and it goes away. So it's really a journey, and we've actually, walked this journey, and some of our children have graduated, they've got married, and, it's been a journey, and you have a dynamic relationship with the family, with the school, with the peers. So it's good that you involve all the players, and it's always good to identify one person. Usually one parent is easier to work with than the other, and you kind of take that person aside and explain. And of course, the initial shock, the acceptance takes time. Yes. It can be quite shocking and devastating initially. And I think the biggest devastation is the thought of an insulin needle. So showing them how small the needle is, giving them the first injection, I think it takes away the fear. That fear factor is the biggest, I think. So acceptance does take time, it takes effort. We have to keep calm as a doctor, and I think the communication skills make a big difference. Yeah.
Yes, ma'am. Understood. So how young was your diagnosis of type 1 in a child, ma'am? How much is the youngest stage at which I will also ask Dr. Sarathi? What is the youngest stage of type 1 in your practice which you have picked up?
I had a 6-month-old. Yeah.
What about you, sir?
Yeah, mine is 8-month-old.
Okay. That's what. So that's the youngest stage actually we are also seeing. So that is the reason why I think community awareness is also important, because I think being a small child doesn't mean that we should deny them the food. They have the right to live, so they have the right to eat. So which is why insulin is the one which takes care of their carbohydrate load. And I think the communication skills of the initial doctor is also very important, because the training level of which the doctor has been trained, and the communication with the team, because it's a multidisciplinary team. It involves a dietitian, it involves a diabetic educator, it involves a caregiver who is also been supported, some other person's family who has also taken care to support them. And also important for a system also to recognize, because in Kerala now we have got a social security scheme which supports the child. I think we have got a scheme called Mithai. It's termed as Mithai itself. So it's a social security scheme, and the child is being counseled, and we give insulin free. And I think now pumps are also getting delivered by this way. So I think Kerala is showing the way in that way as well. So I think I'm proud to say that. So I think I would like to know from Dr. Sarathi regarding whether it is a transmitted like any other communication transmissions has been happening, because now COVID times we are going through. Is there any viruses which can also be etiology for this, and whether it's been an infectious origin as well?
I think Mohan, you're asking two different questions. Whether whether this can occur because of an infection. I think as Dr. Kirtida already was mentioning, no, I think it was in one of the previous meet I just attended. where Dr. Manohar was mentioning that there could be some role for COVID infections in the pathogenesis of type 1 diabetes mellitus. So we need to have more data, probably whether regarding the etiopathogenesis, the role of COVID infections in the etiopathogenesis, but looks there may be a role. The second one, I think when you're again asking me whether this type 1 diabetes mellitus is a communicable disease, right? Whether this will be transmitted from one person to another person by touch or by staying in the same environment, or like spending some time in a common areas like being in school or kind of a thing. The answer is absolutely no. It's a completely non-communicable disease. The only of it getting transmitted, as Dr. Kirtida already told, it's only genetic transmission. It can come from parents to offsprings, or these when again they give birth to their children, they may pass it on. Even that transmission is very limited, definitely less than 9%. So not more than that. Even it could be 1 to 4% on an average, right? But like when it comes to a communicable nature of the disease, it's an absolute no. It's not a communicable disease. Nobody has to get afraid to be in touch with a type 1 diabetes patient.
That is true. Thank you, sir. Regarding restriction of sports and activities, I think we have a lot of athletes who has emerged. Recently, we had a car driver who has been the first prize. So I think what's your experience, ma'am, regarding sports and outside activities? Generally, type 1 diabetes, how is it like? I would like to know.
I think children should not be restricted from any sports or activities. Sometimes I get parents coming to ask me to write a letter exempting the child from any sports in school, and I always refuse to write the letter. It causes a lot of taboo in the child's mind. So right from a young age, we encourage the child to take part in every sports and activities in school, unless it's a very bad. If they're having an unwell time, if they're recently out of decay, then for some time we can give them respite. But otherwise, a child with type 1 diabetes should be encouraged to take part in every sport and activity in school. In fact, most of the type 1 diabetic patients I look after are champions in their various sports. We have had kids winning awards. Some of our long distance runners have type 1 diabetes in Kenya. We've had children climb Mount Kenya and Mount Kilimanjaro here in Kenya. So we're so proud of them. They carry the insulin with them. When they summit, it's right inside them, and then they've worn the warm clothing, so the insulin doesn't freeze up. And there is nothing a child can do, but they need to work with the nutritionist, the diabetologist, and the exercise physiologist, so that they don't get hypo and hyperhydration, the changing of the dose during the vigorous sports activity. That is very important. We can't just be blasé and say, go run a marathon, go climb a mountain, go swim, in the Olympics. We need to prepare them so that there is no major glucose variability. Some of the children are fortunate enough to have the insulin pumps or have the top of the range devices. It depends on the socioeconomic status, but many of them are from underprivileged communities, and they're still doing very well in their school, in their sports. So I think the limit is not physical, it's in the mind. And we have to change the mindset.
True, ma'am. True, ma'am. So I think we have discussed the initial part regarding the myths so now we are going into the next part of the discussion regarding challenges. So I think the first challenge is actually the growth of the children. So Dr. Sarathi, can you shed some light on how that type 1 diabetic children how to ensure that they are growing at the pace? So is there any other ways in which we should improve their nutrition?
Yes. In fact, like if you look at the type 1 diabetic children, they will have a normal growth at the time of diagnosis. In fact, few may be taller than usual. That's the usual trend we see. But like if we don't control the sugars well, or a few or more years, so the uncontrolled blood sugar persists for a longer while, that can definitely affect the growth, and it can also affect the onset of puberty as well as progression of puberty. So which is also will contribute for the impaired growth, right? So as you already mentioned, in fact, there are also some increased occurrence of some other autoimmune disorders like primary hypothyroidism, that's like thyroid hormone deficiency, and celiac disease, where there is an allergy to wheat. These two disorders can also contribute, in fact, can significantly affect the growth of type 1 diabetes children when they co-occur with type 1 diabetes. The beauty of identifying these disorders is both of them are very well treatable, right? So in fact, much easier than managing a type 1 diabetes is to treat them. So obviously, whenever we have a child with the severe impairment of the growth, we should definitely check for them. So not only that, even without any growth affection, it's always good that we regularly monitor for these disorders even before they can manifest and impair the growth of the child. Really, even some complications of type 1 diabetes mellitus, like occurrence of a chronic kidney disease, can also contribute for the affection of growth. In fact, there's also something called as a Mauriac syndrome, like where there is a intermittent skipping of insulin or intermittent underdosing of insulin, where the baby survives but he does not grow well, right? So there will also enlargement of the liver in these children because of accumulation of glycogen. So they look very chubby but short. So there's also one extreme of growth impairment which typically seen in type 1 diabetic patients who are not managed well. So definitely, like, we have to take the challenges here to optimize the growth of the children, where I'm going to provide a good glycemic control, right? Also, I'm going to screen regularly for the autoimmune disorders like hypothyroidism and celiac disease, okay? But most importantly, this very, very important thing is to monitor the growth and puberty of the children, irrespective of they have a good glycemic control or a poor glycemic control. They have manifestations of other autoimmune disorders. That probably is the one thing which can clinch not only that we have to do something for the growth, but could also be a clue for identification of the other associated disorders quite often.
That's nice. So as we know, insulin is the mainstay of type 1 diabetes, and insulin is given ideally in a basal bolus manner. That means we have to give a basal dose, which is in the night, and 3 bolus doses to take care of the eating pattern. So I think we have to understand that unless we properly manage diabetes, type 1 diabetes, they can lead into complications. And childhood complications are very much very bad because they skip on to the future, and the child has to continue with this in the adulthood as well. So I would like to know from Dr. Kirtida regarding the education status and how that competitive exams, how these type 1 diabetic individuals, because we know that it is a stressful environment, and the way they are educated is also very important for their careers. So we have had experience, we have a lot of doctors who are coming up from the type 1 community as well. So I would like to know from you regarding the educations and the competitive exams which type 1 diabetic.
Sure. In fact, most of the children we have here, we do youth camps for them and children's camps. And when we ask them what they want to be when they grow up, I think 90% of them say they want to be doctors. So I think somehow we inspire them because they spend a lot of time with us. A few of them say they want to be pilots, and I really cringe when they say that, because unless they go to Canada, at least here in Kenya, they won't be allowed because the aviation licensing authority is quite strict. But basically, we really empower them that they should, they should not feel limited in any way, even academically. And good glycemic control is very important for that, because sometimes in class they do have lapses, with frequent hypoglycemia, hyperglycemia, glycemic variability. They do say sometimes they find it difficult to concentrate in class. One of the things we empower them that if they feel unwell in class, they need to speak out, especially the younger children are afraid to speak out. So we do tell them that they need to raise their hand and tell the teacher they need to, if they need to go to the bathroom for a short call, if the sugars are high, if they need to eat a snack, if they feel unwell in any way. Here in Kenya, we've been going to schools and giving talks to any child with type 1 diabetes. We actually go to the school and we speak to the teachers, we speak to the other children. So first of all, the child is not treated like there's something wrong with them. And if there's an emergency, hypoglycemia, then the other children know what to do. And the child is also not ostracized or treated like there's something wrong with them when they're injecting, and when they may be eating slightly different food. So we are trying as much as possible to cover every school possible. So we are running a school's education program. But the child, in terms of academic progress, we find again our children with diabetes are the champions, not just in sports, even academically they do very well. And we also encourage them not to miss school days. So unless they're feeling really unwell, we encourage them not to have, to miss school. During COVID, there was a lot of online schooling going on as well. So most of them, they were learning from home. And again, they really, most of our children are very good. They formed a good relationship with us as their doctors, and they do communicate with us and they share their results with us. So they do very well academically, and they also do a lot of extracurricular activities as well, not just sports. They're very good in drama, poetry, art. I think they express themselves. I have a lot of paintings in my clinic from the kids that I look after. And here in Kenya, we don't have enough pediatric endocrinologists. So and also I think certain communities, I think the Asian community, they prefer, for example, because of language barrier, they prefer having an Indian doctor. So we don't have enough Indian pediatric endocrinologists. So most of the Indian patients will probably come to an adult endocrinologist who speaks, for example, Gujarati or Hindi or Punjabi. So because of that, you see, we end up looking after the pediatric type 1 as adult endocrinologists. So basically, the children, they keep communicating and sharing the results and the marks as well. But even in a lot of the Kenyan patients who come from underprivileged communities, the slums areas, we follow them up, empower them, and they're top of the class. So for some reason, I think once a child gets type 1 diabetes, I think they raise their own bar very high, that they will excel, and the diabetes gives them a form of discipline because they're injecting themselves and they're monitoring their sugars, and they're looking at what food they're eating. They tend to get disciplined with their sleep pattern, their wake up pattern, their studying patterns. So for some reason, I find all the children I look after are also mentally they mature much quicker. So I find they're really, really disciplined and become very good peers, peer leaders and champions in their schools.
Very nice.
I hope that answers the
Yes,
question.
ma'am. Yes, ma'am. Very nice. So also there was a thought regarding including type 1 diabetes in the Disabilities Act because they used to miss classes often, and also because they actually had some struggles in their careers. So that's the reason why we used to. There was a thought regarding including them because many other issues are there in which they need to be brought to the front line. And I think now the government is working on many other, because other communities, just like other disabilities, whether type 1 because they are requiring insulin for their life, and every exam and everywhere they go they have to carry that. So that itself makes a lot of responsibility from the community side as well. So I think we also encourage them to carry with them the letter of the doctor wherever they go, because if they suppose they are going to join some place outside which some other doctor wants to go through the records, they are also encouraged to carry a letter of their what a treatment which the doctor has been giving them. And insulin is available almost everywhere now. So I think that options among insulins also, they are nowadays we have doctors, patients who are wanting to try newer insulins as well. So experimentation is also common among the type 1 community. We also have with us Dr. Pooja Poonam Yadav. She's a dentist. I think we have Jadhav. She's actually a part of our type 1 diabetes task force. I think she is running a clinic in Bhopal, in Indore, and I think very, 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 very happy to tell her, because she has written a lot of blogs regarding the type 1 diabetic communities and how she's been able to communicate among her peers, and she's able to support her community in that way. So I think now we'll go to the next challenge with Dr. Sarathi will address regarding pregnancy. So as we know, pregnancy and childbirth is the most pleasurable sensations and the phase of life which a child has to go through in the future. So raising a family is also important. So what do they have to think regarding pregnancy, Dr. Sarathi?
Yes, of course, pregnancy can be opted by any woman with type 1 diabetes mellitus, but they need to definitely follow some precautions, right? In fact, the planning for pregnancy should start at least 6 months prior the true conception, right? Where they have been maintaining a good glucose control throughout the 6 months, and then they are taking a chance for conception. That will have one of the best outcomes, I can assure. See, in fact, the problems which come in type 1 diabetic mothers are actually of two different types. So a poor glucose control in the first trimester will lead to a different set of problems, right? So because that's the phase of organ formation for the fetus. So if the glucose control is not good, that's going to be pretty detrimental because it can impact the formation of the organs, right? Especially of a heart formation as well as the nervous system formation. So that's why it's very, very important that glucose is well controlled in the first trimester, even for a few months preceding the pregnancy. Even controlling the glucose for the rest of the pregnancy is also important, because if the sugars are not controlled well, there is an increased chances of miscarriages, okay, there's increased chances of early deliveries. Okay, the baby may get delivered by around 24 to 28 weeks, or even sometimes even 30, 32 weeks. Earlier the baby is born, obviously the baby will be born with immature lungs. A lot of issues will come, including survival, right? So in fact, this can also impact the blood pressure of the mother. Many people may develop, hypertension. Some people may develop severe hypertension, or we call it as preeclampsia and eclampsia, right? And there are also other features or effects on the fetus itself, right? There's a baby inside the womb. So what could be the effect? Because there is a deficiency of insulin in the mother and uncontrolled, if it is, then there'll be high glucose in the mother, which will get passed on to the baby. But there is the pancreas of the fetus, which is normally functioning, right? So that produces more insulin. So obviously the baby gains weight. So probably there could be chances of, excess weight gain in the fetus, which will lead to further problems during the delivery. And also it increases the chances of low blood sugar incidences in the baby within the first few days after birth. So in fact, like when the sugars are very uncontrolled, even the fetal growth may get affected, right? So for all these reasons, it's very, very important that the glucose levels of the mother is maintained and a good control throughout the pregnancy, so that the effects on the baby as well as the mother could be minimized. But of course, it's a challenge. So we need to definitely have to work with the mother, right? So we have to, address her diet, our insulin regime, and we may have to consider the changes in the insulins as and when required. For example, typically in the first trimester, the insulin sensitivity is better. So we may have to slightly reduce the doses. But as and when we're approaching towards 24 or 28 weeks of the pregnancy, there's a need for increasing the dose of insulin, so which needs to be addressed closely, right? And also most importantly, the modifying the diet of the type 1 diabetes mother who is pregnant, right? We need to give more amount of proteins and fats and reduce the amount of carbohydrates, which probably definitely a difficult task for the mother, but probably that would help her to control her blood sugars.
Thank you, sir. So, Dr. Kirti, the question is to you next regarding the challenge. One of the challenges which we also are finding is diabetic distress, and depression is also there among the youth going into. So many are situations where I think, despite we are not trained in mental health, we may have to take a lead in this as well. So, what are your thoughts regarding diabetic distress?
Thank you. A very important question, and we are the first port of call. We have to recognize it before we can refer them to a psychologist or a psychiatrist as and when needed. And many times they will talk to us first. And like I said, recognition is the first step. Yeah, we can only treat it if we pick it up. It's actually very common. And many times it happens when the child is transitioning into adolescence or adulthood, because puberty hormones are coming in. So that's one of the times it's happening. Many times when the child during teenage or adolescence, you see the children, the young adults are now, they are going to parties, or they want to go on holiday, or they've now got a relationship issue. So that time acceptance is one of the reasons, can they give insulin if they want to take alcohol, they want to go clubbing or pubbing, sexual relationships are being formed. So again, some of the younger boys are starting to get erectile dysfunction, libido issues, and then they don't know who to talk to about it. Their questions for the young girl, marriage proposals are coming in. Can she disclose the type 1 diabetes? There are so many reasons for the dilemma. Some of them are going into university, their fears. I've had parents who don't want to send their children away to another country despite them getting scholarships or economically being able to afford it. They don't want to part from their children. They're worried about hypoglycemia. I had one young boy who went to Malaysia or somewhere. He got into a really good university, into the course of his dreams. And when they were in a shopping mall, he got a hypoglycemia and he collapsed. And the parents brought him back on the next flight. They couldn't cope with it. So, all the dreams and everything gets, crashed. So there are many reasons for the diabetes distress, economic, psychological, so many reasons. So it's sometimes good. And, when the sugars start fluctuating, it's one of the reasons is to sit down, and sometimes I even ask the parents to go out and I ask the young patient, even if it's a kid, I ask them, is there anything happening? Is there something bothering you? It's not always because of another endocrine issue. Many times it's up there, and the stress hormones really play up with the sugars. And it's very important to address them And I think the diabetes support groups, we have introduced the young diabetics, not very young, but the older age groups, to each other. So we have peer support groups, and it helps when they talk to each other. So we have to find support systems for them. And when they talk to each other, and then we tell them, if there's something you're not sure about medically, always come back to us. Some of the children think marijuana helps in diabetes, some of the drugs. So we have to tell them, please, if there's something you're not sure about, come back and medically talk to us. We are your friends. We've had excursions with them. We've had, we don't always want to do workshops where we're talking just time. So we've had friendly ways of talking to them, and we want to be their friends, and we want to be, sometimes the parents are very much like, don't do this, don't do that. We allow them once in a while, if they want to have a drink, they want to share a beer, they want to have, like you said, the mithai, they want to have, they can have their chocolate and the cake and all that. They just need to know how to, how to play around with the insulin doses. So it's very important that we are their friends. Again, giving them the right education, the empowerment, the material. There's so many apps now. There's so much that, we can help them with. I just wanted to share with you, there's this global magazine. I think you're aware of it, Dr. Chennai, and we have so many Indian authors. Dr. Kalra has written. This is a global empowerment magazine called Diabetes. And this one is specifically written for type 1 patients living with type 1. And we had some very powerful stories. And we have now ambassadors for type 1 in every country. And Dr. Gagan Priya is one of our ambassadors as well. And she really writes beautiful, motivating poems for our patients. And another thing is, our patients with type 1 diabetes, anytime we have a World Diabetes Day event, we don't get people to come and do the activities or the entertainment. We don't get the local people to come and do whether it's singing or dancing. We don't get people from we don't pay people to come and do it. We get our patients living with type 1 diabetes to run the whole event in the show. So from the MC to the music to the dancing, the choreography, the whole event is run by people living with type 1 diabetes, and they do wonderful, amazing events. So when we motivate our patients, they have a whole they can overcome their distress. So we just have to find a way of letting them. They have to emote. They have to talk. And nowadays, with social media and with just forming networks and bridges, there is a lot we can do to help our patients. And here in Kenya, we find, if we have a buddy system of pairing up somebody from a socially privileged background to somebody who's not socially privileged, and we team them up, people with type 1 diabetes, they can work together and achieve a lot more. So that's what we are doing now.
I think I would also I think Diabetes, it's a free magazine. I think it's
online. The soft copy is free, and when somebody wants a hard copy, there's a very minimal cost because of the publishing, because of the printing.
Okay. I'll take that.
I can share with you.
I will take the address, because I think that is motivating all of us to, I think, write and prepare more. So I think we have crossed the two sections regarding the initial discussion as well as the challenges. Now comes the opportunities and practical solutions. The next 10 minutes we'll focus on that. From Sarathi, Doctor, I would like to know regarding new preparations of insulin, how they are also helpful, because I think initial insulins, we all know that they used to have some issues. So newer insulins are available, and there are a lot of new preparations as well. So I would like to know from you, sir, regarding that, how they help in the hypoglycemia as well.
Right. That's a good question, Mohan. In fact, we always had conventional insulins for years together, right? But I need to understand that type 1 diabetes children could still be managed on these conventional insulins. But of course, there are some disadvantages. For example, you take regular insulin and NPH insulin. Regular was always used to cover up a meal, but especially for Indians, especially for South Indians, right? So we take some diet which is very high glycemic, right? So they have a very high glycemic index diet. The peak of insulin action that comes with the regular insulin can never match the peak of glucose which is provided by the South Indian diet. So obviously, we are very happy that we have now got the newer insulin analogs, though they can still not match that peak. At least they're going closer to it, especially when you're looking at the nearmost insulin, that's the fast-acting aspart, which has the fastest action, right? Again, the other problem what we had with the regular insulin was the shoulder effect, because that used to act up to 6 to 8 hours, wherever the high glycemic index diet used to finish off their supply by around 3 to 4 hours, right? So there was some chances of having hypoglycemias after the 3 to 4 hours of the meal, maybe just before the next meal. Now, again, with these ultra short acting insulins, we are able to better control these low glucose episodes. Again, if you look at the basal insulins, when we're using this NPH, in fact, the NPH insulin has a high variability. Today, it's doing some kind of an action. Tomorrow, it's giving a larger action. But again, third day, it's giving a lower action. So it's very variable, right? Again, that has a pretty, a pretty good peak. So where I have taken my last meals many hours ago, but the insulin is giving a larger action after 6 to 8 hours, where there was a chance for a type 1 diabetic child to have a low blood glucose. But of course, now we have the analog basal insulins where we don't have much variability, we don't have much peak, right? So it's almost giving a good, smooth basal coverage, definitely contributing for lower prevalences of hypoglycemia. But at the end, because as Dr. Kirtida is here, and there are patients, even in India, where children are struggling to get insulins, definitely we need to go with the point. Though there are advantages with the newer insulins, even the conventional insulins like regular insulin and NPH insulin could still be good alternatives. Definitely, we can almost equal job we can get with regular and NPH insulins.
That is nice. So, Dr. Kirtida, regarding your thoughts regarding improved delivery devices, I think now we have previously used to have syringes. I think now we are going into the generation of pens and now pumps as well. So, what are your thoughts regarding that?
They are wonderful devices if you can afford them. So pens, of course, the pens, they can fit into the pocket. You don't need to keep them in the fridge. The needles are much smaller. So once somebody starts using a pen, they really don't want to go back to a needle and syringe. And, it's really revolutionized the management of diabetes, definitely. Any type 1, type 2. We have about 60 patients in Kenya on a pump, and they are really happy. Their glycemic variability is really under control. Their brittle diabetes is under control, but they are expensive. So it's really made a huge difference to them. But the insurance is, there's just so much that they'll pay for them. Many patients don't have insurance, so it's a fortunate few who have the pumps. But we do pump workshops for them, and they're very happy. But like very few people in the world, anywhere in the world, will be able to have the pumps. More and more patients have the pens, so the pens are making a big difference. And even with the pumps, we have different types of pumps, and different devices. I think as more people use them, it's going to become more affordable, just like the mobile phones. We also hear about smart insulin, and we hear about nasal insulin and maybe an oral insulin someday. But at the same time, as these newer devices and things are coming in, we really need to be careful about messages on social media, and people not getting conned as well as to what is available. And at the same time, like Professor Sarki said, even with we cut your cloth, your quote according to your cloth, and depending on the patient and their pocket and what is available, we can use any type of insulin so long as we keep the sugar within range. So it's nice to have the smart devices, and we have many. So even in Kenya, we have the pump, we have the top of the range pens, we have the devices. We can also do continuous glucose monitoring for the patients who we need to do it on. But we just have to see what the patient can afford, and we still have to lobby for insurances to pay more, so we can prescribe it more.
Thank you. So there are a lot of initiatives taken from all the government level, private level. So we should all try and get the voice together. Dr. Sarathi, your thoughts regarding the advanced glucose monitoring? I think previously we still do the continuous glucose. We still used to do the SMBG or the self-monitored glucose. I would love to know from you regarding the continuous glucose monitoring techniques and how they are going to really help in type 1 diabetic.
Right, Mohan, definitely, for most of the type 1 diabetic patients, even today, SMBG, that means like self-monitored blood glucose using a glucometer, is the standard of care. But definitely, continuous glucose monitor has given some advantage for the management of glucose levels in these type 1 diabetic patients. So there's several continuous glucose monitors available. Some we can use for around 7 days, some we can use for 14 days, right? So what they do is that they provide the data of the glucose levels 24/7. Okay. So what the advantage of this is that, by studying the behavior of the glucose in a given patient or 24/7 for, or even 24/14. So I will get to understand like how a particular type 1 diabetic patient is behaving for an insulin dose, how that person is behaving for the intake of food, how he is behaving for a given activity. So right, that helped me to understand like how this particular patient is responding for these three important things. Then once I have a trend, so then I know how to modify the insulin doses or the activity or the food according to the data which we have got from the continuous glucose monitors. Definitely it will help to modify the regimes better. Definitely then we can get a most of what we call as a time in range now, right? So what we can maintain the glucose in a given range in a better way if we are using this continuous glucose monitors. So definitely even the overall glucose control can be increased, right? In fact, the good part is that we recently have some CGMs which are affordable. Probably these were not much affordable in the past, relatively better affordable in the recent days. And of course, recently even the patient versions have been introduced, right? So earlier, probably till last year, every time if they have to get it, like they have to go to doctors. But now we have patient versions where patient himself can get the reading and can analyze and can transfer the data to the doctor without making a physical visit to the doctor. So definitely these are going to be advantageous, but still SMBG remains the standard of care for most of the patients.
Got it, sir. So regarding telemedicine is the next concept. So telemedicine technology has actually transformed a lot of doctors because we are able to connect to our patients in a very easier manner, and patients as well, because chronic diseases, they are coming in a very smoother manner, because last year onwards, I think it is legal, and I think there is a framework also available in telemedicine. So just a word about that, because telemedicine is actually getting established in every part of India. And we know that charting the glucose values in a paper is tedious sometimes. So I think there are newer devices which also capture it in a Bluetooth manner, and the system also readily gets into the picture. So I think there are many simplified versions of telemedicine available. I think there are each and every way. I think there are many mediums like video calls, visual accessories, audios. So there are many ways in which telemedicine has also impacted the modern healthcare practice. I would like to know from both of you. I think this is an out of the box question. How you are using it in your clinical practice in type 1 diabetes? First, Dr. Sarathi.
Yeah, I think like probably that has become the rule nowadays, right? So most of my type 1 diabetic kids are not coming to my hospital. Most of them either contact on phone, because I have given that liberty for them to contact, because I don't want them to end up in emergencies without my knowledge. So most of these communications are actually occurring on phone. In fact, like I don't take consultations for my type 1 diabetic patients. I have made them completely free, whether they may come to my hospital or they contact me on phone. But of course, there are a few patients who are actually communicating me through some apps which we are using for regular consultations. There probably the documentation is only better. Otherwise, the management is going equally well for whether I take them on a phone or I take them on an app. But definitely, in fact, like 100% of consultations, at least in the last 3 months, has gone only on this telemedicine. So no direct consultations. In fact, like only in the last week, I could see 2 type 1 diabetic patients who pitched into my clinic. That too because we give free insulin for some type 1 diabetic patients. They just came for the sake of collecting insulin.
Nice. What about you, ma'am? Regarding your part, how is the telemedicine facilities? The acceptance is high, and how is it like?
The acceptance since COVID and lockdown has been really good. So both type 1, type 2, even the pregnant women, they don't really want to come to hospital. They are afraid. So during lockdown, and also a lot of my patients are not just all in Nairobi, they are outside of Nairobi as well. So people, there was county lockdown, people could not travel. So since COVID has revolutionized medicine and the uptake has been very good, but there are some patients who still are old fashioned. They want to see the doctor. So since the lockdown was released, people have started coming back. But generally, people are really happy. They share their sugar readings and we titrate the insulin. So it's been, I think it has really revolutionized medicine and the uptake is very good. So a lot of the younger kids are very, they're very good with telemedicine. So they're quite happy to be managed that way. Yeah.
Okay. So I think nearly 1 hour we have spent, ma'am, sir. I think the time has gone. I'm just looking to the clock now. I think we just want a word from both of you as the final your remarks. First, Dr. Kirtida, how is in type 1 diabetes, how you are able to manage, any special message for them?
I think patients with type 1 diabetes, their families, the whole, everybody, they should not despair. They should not feel defeated. Life can continue even better than before. It's all a mindset. So I think the most important thing is allow them to be and to flourish and to live a healthy life. Stay free of complications, avoid sugar fluctuations. And these children should be really motivated. They should be empowered. We should allow them to be comfortable and come and communicate with us if anything is troubling them, if anybody is bullying them in school, because some of these children at a younger age, I find have been bullied, when they're injecting the insulin or when they're eating special food. So right from a young age, we really need to work with them, work with the family members, remove the myths. At the moment, the myths are really bad. They're shrouded in mystery. So we need to continue dynamically being mythbusters for them. And this is a journey that's going to continue right from the time of diagnosis. And it's a journey not just with the child or the patient, it's with their parents, it's with their school, it's going to be with the future employers, the rest of the extended family, because whether it's India or Africa, the whole, everybody, even the neighbor will come and give their 2 cents worth of their opinion and their advice. And also with social media, with all the messages going around, even here in Kenya, we've had children stopping their insulin. And at the same time, if somebody has prayed for them or somebody's, given them some alternative herbal medicine, and if the honeymoon period has coincided at the same time, somebody else takes credit for it, that the diabetes was cured because of so-and-so's intervention. So I think that has done a lot of harm more than good. So we really need to, an empowered patient is half the battle won. So we need to warn them about the natural pathogenesis, that in type 1 diabetes, a honeymoon period will come, but a honeymoon never lasts forever. So I think if we empower our patients, we walk with them, we are always available for them. I think these children do marvelously well. There is no reason why somebody with type 1 diabetes cannot live a normal life, get married, have children, and one day even fly a plane. That's what we hope for. That's the only thing they're being restricted from. But otherwise, they should be able to do anything and everything, and do it even better than other people because of that discipline.
Yes. Thank you.
So we will have to give the wings. We will have to put the wind under the wing.
Yes.
Yeah.
What about you, sir?
Thank you.
Your concluding remarks.
Yeah, Mohan, I just want to echo what Dr. Kirtida told. You see, diagnosis of type 1 diabetes mellitus is not the change of life. As she said, it's just a change of lifestyle. As long as parents give an appropriate care to the child. So probably it's a time just both the type 1 diabetic kids as well as their parents have to just learn how to live happily with the type 1 diabetes mellitus. With that, the life will definitely be beautiful.
Thank you. So I think we have come to the end of the show. I think it was a pleasure talking to both of you. And I should really thank you for your time and your patience. I should also thank the Endocrine Society of India for giving us the opportunity. I think the endocrine awareness is a big community we are actually in the last 1-2 years we have been building. I think we are encouraging you to write to us. The feedbacks are always welcome. The address is endocrineawareness@gmail.com. We have got our Facebook page, Instagram page, as well as a website. So we look forward to your suggestions and feedback. And the next episode, we'll bring to you a new topic and a new way in which we have to approach type 1 diabetes. So I thank all of you for the kind listening and spending the evening with us. Thank you very much.
Thank you, Mohan. Thank you, Kirtida, ma'am.
Thank you. Thank you so much. Okay. Bye.
Thank you, Mintu. Bye.
Okay. Thank you. Bye.